And I wanted to introduce the next speaker. This is Dr. Dinesh Thavendiranathan, who is a cardiologist at the Toronto General Hospital and associate professor of medicine at the University of Toronto. His research involves the use of cardiac imaging for the diagnosis and prognosis of cardiovascular disease in patients with cancer. He's the director of the Ted Rogers Program in Cardiotoxicity Prevention and holds a Canadian Research Chair in Cardio-Oncology. His talk is entitled Cardiovascular Toxicity in Breast Cancer, Detection and Prevention Strategies.
Thank you very much, and it's an absolute honor to be here to be the token cardiologist in this meeting. I've been attending some of the breast cancer symposiums, and it's really like drinking from a fire hydrant, so hats off to all of you guys. I have no relevant disclosures, and Susan spoke about novel cancer therapies in breast cancer. I'm going to go back to the basics and really speak about, again, anthracyclines and trastuzumab, so I apologize ahead if that bores you. So I'm going to speak about cardiovascular disease, the spectrum of cardiovascular disease seen in patients with breast cancer. I'm going to discuss primary prevention strategies and monitoring strategies, some of the strengths and limitations of these strategies. I'm going to discuss optimal techniques to detect cardiovascular disease. And I'm going to highlight the ESC cardio-oncology guidelines, which I had the privilege of participating in, and these were published about 3 months ago. So the spectrum of cardiovascular disease in patients with breast cancer is quite broad, and you heard about some of this from our last two presenters. This includes congestive heart failure, ischemic heart disease, cerebral vascular disease, and arrhythmias. There are many drivers for cardiovascular disease in these patients. This includes pre-existing cardiovascular disease and shared risk factors for cancer and cardiovascular disease, the development of new risk factors such as dyslipidemia in some of our patients, the impact of cancer and inflammation on cardiovascular disease, the cancer therapy itself, and finally, the limited post-therapy cardiovascular care these patients get. I'm going to focus on two entities, heart failure and myocarditis, because as oncologists, this is probably what you will see while you're caring for your patients. Many of the other cardiovascular events we see in long-term follow-up. So let's start by talking about anthracyclines. We have learned with a lot of data that patients who receive anthracycline-based therapy and develop cardiotoxicity have poor prognosis. When you carefully follow patients with repeated imaging for 6 to 7 years, as done in this study, about 10% of patients will develop cardiotoxicity, and the definition is on the slide. And what was interesting is that almost all cardiotoxicity events, in fact, occurred within the first year after completion of anthracycline-based therapy. Early detection is important because the same authors have shown that the earlier we start heart failure therapy, the greater the chance of recovery of heart function in these patients. But despite doing this, when we use an EF-based strategy to follow patients, about 90% of patients will not have complete recovery of heart function. And this seems to matter. In patients who don't have complete recovery of ventricular function, these patients then go on to develop major adverse cardiovascular events, which includes cardiac death, admission for heart failure, as well as sometimes even a need for pacemaker. Patients receiving trastuzumab-based therapy, much of the literature in cardio-oncology has been in the context of sequential therapy with anthracyclines and trastuzumab. Once you develop heart failure, these patients require readmissions for heart failure. And this interesting study from a colleague in Memorial Sloan Kettering looked at patients who were receiving sequential therapy and developed cardiotoxicity. He brought these patients back for follow-up 7 years later, and these patients had persistent left ventricular dysfunction and significantly reduced cardiopulmonary fitness, which we now know is associated with poor quality of life and is associated with worse survival in patients with cancer. So hopefully that is slightly convincing that cardiovascular monitoring is important in these patients. So how do we prevent cardiovascular disease? The first is consideration of primary prevention strategies. As cardiologists, when patients see us for heart failure, the common class of drugs that are used to treat heart failure are neurohormonal blockade. So why not study this in the primary prevention setting? There's been a large number of studies that have looked at neurohormonal blockade for prevention of development of heart failure. I'm just highlighting one study here. This is perhaps the most recent study that's published. In patients who are receiving trastuzumab, neurohormonal blockade, carvedilol and lisinopril did not decrease the risk of cardiotoxicity. However, when you look at the high-risk patients, these are patients who are receiving sequential therapy with anthracyclines and trastuzumab, both carvedilol and lisinopril initiated prior to the initiation of cardiotoxic therapy did decrease the risk of cardiotoxicity. Here's a meta-analysis that has put all the studies together, about 17 trials, and this study essentially shows that you, on average, prevent about a 4% decrement in left ventricular ejection fraction, but most importantly, this meta-analysis highlighted the deficiencies in the data, the heterogeneity in the populations that are studied, and also emphasized the importance of collaboration between oncologists and cardiologists to do larger trials that are focused on important clinical outcomes, such as clinical heart failure. Another class of drugs that have had a lot of traction for primary prevention is dexiroxane. This is a drug that inhibits reactive oxygen species production by inhibiting binding to iron, as well as binding to topoisomerase 2 beta. And this has been studied specifically in the context of breast cancer, mostly advanced breast cancer. And this meta-analysis, in fact, showed a remarkable reduction in clinical heart failure and cardiovascular events without worsening oncological outcomes. But at this present, the only FDA indication to prevent cardiotoxicity is in women with metastatic breast cancer who have received more than 300 milligrams per meter squared of cumulative anthracycline therapy or cumulative doxorubicin dose. And currently, in clinical practice, I tend to use these in patients who are at high risk. For example, the pediatric cancer survivor who's unfortunate to have now developed breast cancer and requires additional anthracycline-based therapy, and I've continued to use this sometimes off-label. The other class of drugs that have also garnered a lot of interest is statins. A number of retrospective studies that have now shown that the use of statins seem to reduce the risk of clinical heart failure. The only study that has been done systematically so far, published a few months back, is this trial that looked at patients receiving anthracycline-based therapy. Majority of these patients had breast cancer, and we used the gold standard technique, which is cardiac MRI, to follow patients. And at 2 years, there was no difference in left ventricular ejection fraction between the statin-treated group and placebo. There are a lot of challenges with this study. A third of patients were missing primary outcomes. This is probably one of the limitations of doing a trial in the pandemic period, especially when the primary goal here was to prevent a side effect as opposed to treat breast cancer. And the study really focused on non-high-risk patients, as opposed to the primary benefit of primary prevention is likely in high-risk patients. Though this highlights one of the biggest challenges we have in cardio-oncology, which is risk stratification. Which patients are at increased risk of cardiotoxicity hence warrant more closer monitoring? The ASCO guidelines about 5 years ago did provide us some guidance. They suggested higher doses of anthracycline, radiation doses, having cardiovascular risk factors, and lower doses, but in combinations can increase the risk of cardiotoxicity. And several studies such as this in a large cohort of patients have shown us that patients who have low normal or slightly reduced heart function, ejection fraction, prior to initiation of anthracycline-based therapy is associated with symptomatic heart failure and cardiovascular death. But how do we put all of this together? And a few years back, we published the breast cancer risk score. This is called the B-risk score, where we used clinical factors and population-based data to determine the 5- and 10-year risk of all forms of cardiovascular disease in patients with breast cancer, and we used close to about 100,000 patients. This still requires external validation. The ESC guidelines have focused on these proforma. So these were published a few years back. This was an expert consensus-based document which took some of the most common cancer therapies, and a bunch of us sat together in the room and said, well, these risk factors are probably important in identifying cardiovascular risk. This includes patient-specific data, imaging data, and biomarker data. You could add these risk factors together to determine if your patient is at low, intermediate, high, or very high risk of cardiotoxicity. I want to emphasize again, this is expert consensus-based document and external validation is still pending. But everything I talk about going forward as it relates to ESC guidelines did use these proformas to determine patient-specific risk. So take-home points for primary prevention of heart failure: there are no established primary prevention strategies. In high and very high-risk patients, beta blockers and ACE inhibitors could be considered. I use both of these drugs if the patients can tolerate it. Dexiroxane can be considered in patients who are receiving high anthracycline dose. I provide an example of patients in whom I tend to use this. And the ESC guidelines have provided a class 2A indication for both of these drugs in primary prevention. The role of statins is unclear. There are 2 more studies I'll be reporting early next year in higher risk patients, so we'll see if statins are preventive. And where we really need to be when we're studying primary prevention is to consider risk-based primary prevention strategies and considering these strategies in our high-risk patients. So I've shown you that cardiotoxicity is a problem, primary prevention specific for heart failure an issue. So then how do we detect left ventricular dysfunction when it occurs in patients? And this is through surveillance. So the first question is, does surveillance matter? This is again another nice study from the Memorial Sloan Kettering group that looked at patients who developed clinical full-blown heart failure. These were patients who were receiving HER2-targeted therapy. They matched these patients to those who did not develop heart failure, and their focus was on surveillance. So there are a bunch of points here. The first is surveillance at baseline is good, but when you follow patients over time, the surveillance drops off. But what's interesting is that in patients who had surveillance, all of those who developed clinical full-blown heart failure, in fact, did have a reduction in their ejection fraction during surveillance. So if you were able to detect this and initiate heart failure therapy, we may have been able to prevent clinical heart failure. There also seems to be a gap in imaging and a risk imaging mismatch. So this is gap in imaging where you can see in patients receiving trastuzumab therapy, again, baseline imaging seems to be reasonable, but once you follow patients over time, imaging seems to fall off. And what to me was interesting is whether you are below the age of 35, so I would consider these patients to be at low risk of cardiotoxicity, or above the age of 65, the compliance was still low, suggesting that we're not using a risk-based approach to titrate our imaging. This is about 20,000 patients from the province of Ontario. We looked at all forms of breast cancer therapy, and regardless of what therapy the patients are receiving, the yellow line on the top shows that if you have one additional heart failure risk factor, such as diabetes or hypertension, you have a 2-fold increase in the risk of developing clinical heart failure. When we went back and looked at compliance with imaging, there was absolutely no relationship between the risk and the compliance with imaging, again suggesting there's potentially a risk imaging mismatch. So again, like I pointed out in the primary prevention strategy, there is a problem with risk stratification, and I think our approaches should be titrated based on risk. And the second challenges we have is probably with the frequency of imaging. I think it is challenging both for our patients and our partners, the oncologists, to follow these patients with repeated imaging when these recommendations for repeated imagings have all been driven by the clinical trials as opposed to based on data. So can we use some data to refine our imaging? And I've showed you the study before. In anthracycline-treated patients, the most common time of cardiotoxicity is 3 and 6 months into treatment. As I mentioned, almost all cardiotoxicity events occurred by 1 year. So if you're doing any surveillance, probably the greatest value is at baseline and 3 and 6 months after completion of anthracycline therapy. This is a study where we followed patients receiving sequential anthracyclines and trastuzumab therapy with cardiac MRI every 3 months. That's the gold standard method. The blue line are patients who develop cardiotoxicity. And you can see the most common time where we identified cardiotoxicity is 3 and 6 months into trastuzumab therapy, so approximately 8 months after initiation of cancer therapy. So perhaps we need to be changing our surveillance strategies to focus again on baseline, perhaps partway through 3 and 6 months and at the end of cancer therapy. But overall, perhaps the evidence is insufficient to change practice, and there are several of my colleagues who are working on looking at studies where we can modify the surveillance strategies and still reduce the risk of heart failure or cardiotoxicity. So now if we're going to do imaging, what should we be doing to follow these patients? So the technique that is recommended is echocardiography, no radiation exposure, plus it provides you a lot more information than just the ejection fraction that we get, for example, from MUGA scans. And amongst the echo techniques, the recommendation is to use 3-dimensional ejection fraction because it is stable, it has low temporal variability, and when we used cardiac MRI as the reference standard, we were able to show that 3D measurements was the best in detecting cardiotoxicity. You may have all heard about global longitudinal strain. I showed you earlier on that once left ventricular ejection fraction falls, many patients don't have complete recovery of heart function, and these patients then go on to develop major adverse cardiovascular events. There's been an interest in finding early myocardial injury, and the 2 markers that have been considered is global longitudinal strain, an echo measure, and troponin, which is a blood biomarker. Global longitudinal strain is something that could be measured in routine echocardiography. Both 3D and GLS can be measured almost in every lab today on routine echocardiography. And we were able to show that an early change in strain prognosticates the future risk of cardiotoxicity and subsequently clinical heart failure. So really the important question is, can we change outcomes in patients by using this more sensitive method? So we performed this multi-center international randomized control trial where we followed patients who were receiving anthracycline-based therapy using a GLS-based guidance to initiate cardioprotective therapy or standard of care following these patients with ejection fraction. As expected, when you use a sensitive method, more patients receive cardioprotective therapy. At 1 year, there was a change in ejection fraction in both groups, but unfortunately this was not statistically significant. But when we looked at the incidence of cardiotoxicity, there was about a 7 to 8% absolute risk reduction, and this was statistically significant. Now, we have followed these patients for two additional years. Unfortunately, again, with COVID, we have had about a 20% loss to follow-up. At the 3-year mark, there is a difference in left ventricular ejection fraction, but not statistically significant. And unfortunately, although the risk of cardiotoxicity is lower, this did not meet the mark for statistical significance. So the role of strain in routine clinical practice still remains undetermined, and it's likely that it will have value in high-risk patients. The second marker that I mentioned is troponin, and troponin is a marker of myocardial injury. In patients receiving anthracyclines or trastuzumab-based therapy, an early increase in troponin seems to identify those patients at risk of heart failure. When we look at this meta-analysis and drill down, it seems to have better specificity than sensitivity. And the value of troponin seems to be in those patients who are receiving more than 240 milligrams per meter squared of doxorubicin equivalent, which is something that perhaps we don't use with breast cancer therapy at this point. We also don't have studies that have actually shown that if you initiate ACE inhibitors or beta blockers in the contemporary era with lower doses of anthracyclines, that we can in fact prevent the subsequent development of clinical heart failure. So take-home points for detection. Imaging is important in identifying left ventricular dysfunction. Echocardiography is the preferred method. As for three-dimensional ejection fraction measurements, they are routinely available in most labs. Global longitudinal strain identifies early myocardial injury, and I pointed out the challenges, which is identifying those patients who benefit the most. It's likely the high and very high-risk patients who benefit from this kind of surveillance, and the frequency and timing of surveillance likely needs to be reassessed. From a biomarker perspective, troponin is the method of choice. It identifies myocardial injury, but again in patients who are receiving higher doses of anthracycline. And the current ESC recommendation is in patients at high or very high risk for cardiotoxicity. With anthracyclines, the suggestion is to perform a baseline measurement of troponin and repeat it during treatment. And in HER2-targeted therapies, again, especially in the context of prior anthracyclines, to perform baseline imaging and baseline measurements and measurements in follow-up. So here is the ESC guidelines. Again, these are available for free, and you can see patients are dichotomized based on their risk of developing cardiotoxicity, and the frequency of surveillance has been suggested based on their risk of developing cardiotoxicity, both for anthracyclines and in patients who are receiving HER2-targeted therapy. And the last part I'll talk about for heart failure is in patients who have metastatic disease. Should surveillance be the same? And Dr. Dent showed this slide, and you can see that probably in the first year, these patients should have similar surveillance every 3 months, like patients with early-stage breast cancer. And after a year of stable ventricular function, the frequency of imaging probably can be reduced. The last few slides, I'll talk about myocarditis. With the use of immune checkpoint inhibitors, we are seeing cardiovascular disease, including myocarditis in these patients. We know there are no prevention strategies, especially with immune checkpoint inhibitors, but detection is important. The first is to have clinical suspicion. We know that the symptoms these patients present with are nonspecific. It includes dyspnea and fatigue as the most common symptoms, and cardiovascular clinical examination is usually normal. The clinical suspicion should also depend on the fact that majority of patients who develop myocarditis, it occurs within the first 6 months, and in fact within the first few cycles of ICI therapy. The marker that's been the most useful in identifying myocarditis is troponin, and particularly high sensitivity troponin, and troponin I is more specific, whereas troponin T is likely more sensitive. So if available, we prefer to use high sensitivity troponin I. We also see that BNP, or NT-proBNP, which is a marker of increased filling pressures of the heart, is also elevated in 2/3 of the patients. So patients presenting with clinical suspicion, we tend to get measurements of both BNP and troponin to help with the diagnosis. The ECG is also helpful. About 2/3 of patients will have an ECG abnormality. That's prolongation of the PR, prolongation of QRS or QT interval, and about 1 in 5 patients will in fact have more advanced heart block that requires implantation of a pacemaker. One thing that we have learned with myocarditis, unlike heart failure, is that the left ventricular ejection fraction does not seem to be particularly helpful. Close to 55% of patients who present with clear diagnosis of myocarditis have normal left ventricular ejection fraction. Again, GLS rises to the head here as well. In patients who have had measurements of global longitudinal strain, a more sensitive marker of myocardial dysfunction, this seems to be reduced at the time of myocarditis. Now, if you don't have a baseline measurement in patients with preserved ejection fraction, again, these patients tend to have reduced global longitudinal strain. Now, the gold standard imaging technique for the diagnosis of myocarditis is cardiac MRI. We use the Lake-Louise criteria, and the Lake-Louise criteria requires the presence of 2 main criteria and supportive criteria. With cardiac MRI, we want to be able to demonstrate myocardial edema, suggesting injury and reaction to injury, and a pattern of non-ischemic myocardial injury. And if your center is doing cardiac MRI, ask for quantitative tissue characterization techniques, because these seem to be better than qualitative tissue characterization techniques for the diagnosis of myocarditis. So take-home points for ICI myocarditis: troponin and BNP are key biomarkers for the diagnosis. Having a baseline, if at all possible in your practice, is quite helpful. ECG is useful, especially in patients if there's a baseline measurement that's available. Left ventricular ejection fraction, as I mentioned, is not a reliable marker of disease. And global longitudinal strain particularly can be helpful if ejection fraction is normal. Cardiac MRI is the reference standard imaging technique for the diagnosis of myocarditis, but if cardiac MRI is also normal, not uncommon in the last 30 patients I've seen, we move on to do a cardiac biopsy, and at the time, if you have not already involved a cardiologist, involve a cardiologist. Many of our heart transplant centers, we do 10 to 20 biopsies per day, because that's how we monitor rejection for heart transplant patients. So it's very common for us to do a cardiac biopsy through a transjugular approach. It's pretty easy. So if needed in a transplant center, this can be done with minimal risk. Again, there have been some surveillance strategies that have been suggested in the ESC guidelines based on risk. For example, high-risk patients for myocarditis are those who are using, for example, dual checkpoint inhibitors in other malignancies, CTLA-4, PD-1, PD-L1, or anti-lag therapies. These are being used together. And patients who have pre-existing cardiovascular disease seem to be at a higher risk of developing myocarditis, and there are some surveillance strategies that have been suggested. So that's all I have. Thank you. I'm happy to answer questions. My email address is there. If you have any additional questions, I'll be more than happy to answer.